Welcome, everyone. I'd like to thank you very much for attending the SPOR program in Primary Integrated Healthcare's workshop on linking policy and research in primary healthcare. You know, a week ago when we were organizing this, we had about 35 people registered, and as of Friday, we're over 80. So we're very pleased that we have this wide of a representation. When CIHR started this program, the SPOR program was intended to try to focus research more on the front line, try to see if we can get research that is going to actually be addressing the issues that are facing healthcare on the front lines. So in our network, the SPOR program is put together with a number of networks. We have the Primary Healthcare and Primary and Integrated Healthcare Network, and we are working to bring together the different streams of interest in primary health care. So we have researchers, we have policymakers, we have clinicians and clinical researchers, and of course we have patients who are involved in making sure that we stay on track. And today we have a representation that is quite wide in this room. From the healthcare professions, we have people from medicine and nursing and physiotherapy, and we have disciplines from geography and sociology and medical education. We have healthcare administrators. We have a couple of carloads of people from the government of Saskatchewan who have driven up this morning. We have people from SciAst, from University of Regina, from University of Saskatchewan. So it's in this room right now, we have a bulk of the people who are focused on primary health care in Saskatchewan. And what we're wanting to do from this day is twofold. Our objective first is to hear about what the government of Saskatchewan's priorities are for the province over the coming years in healthcare. And from there, to bring people to the tables, this will be our session after lunch, bring people to the tables and actually talk about what kind of things that we can do with research to support those to happen. So we're going to tease out what some of the outstanding questions are, where are the issues for implementation. We're going to hear from them what the priorities are going to be. And then in those sessions after lunch, you'll have a chance to talk to the people who are involved in the delivery of health care, probe a little bit more on what the priorities are. I know some of you have projects that are ongoing that you'd like to be able to talk about and see if there's a synchronicity. Part of the end to this is that we have some funding opportunities for research that are going to be coming up. We're hoping by the end of today that we might have been able to tease out what is the beginning of some projects and project teams that might be interested in moving forward in doing applications. There's going to be other opportunities for moving forward with research projects as well, and we'll see what comes out of this. The second objective for this session is really the networking part. As I mentioned, a main part of what we're trying to achieve with this network is to have people who are more knowledgeable about the different areas that are involved. So policymakers, knowing people who are doing the research in the area, knowing the clinicians who are at the front line, understanding just what the different perspectives are so that you're more able to integrate it, whatever your work is. So to that end, we've designed an agenda. We're going to be hearing in more detail about SPOR and what has been happening. Dig a little bit deeper into what we're trying to achieve with the network. That'll be our first session. After that, the Government of Saskatchewan healthcare leadership has put together a presentation on the main priority areas they're going to be hearing. Over lunch, we have a patient orientation, so we have a speaker who's come in from Toronto who has an expertise in patient engagement, and she's going to talk to us about how that can be done, about the benefits of involving patients in right from the genesis in research projects. And then after lunch, that's when we roll up our sleeves and we're going to be doing the discussion and sitting down and saying what actually might be created in Saskatchewan. So to start, we have a presentation that's going to be coming from two of the members of our leadership team. Dr. Corey Newdorf, Dr. Nazim Mahajareen are going to give us a presentation on SPOR PICHI and where this all starts. So if we could welcome them.
Well, folks, this has been a highly anticipated day. Short though, I want to give all kudos to Janice Braden, Joanne Blythe, and others who really worked hard in the last weeks, month and a half to pull off this event. This is the first conversation, I think, of many we are hoping to have about what Saskatchewan's response is to this whole initiative, national initiative. We are beginning to know as patient-oriented research, strategy for patient-oriented research, and within that, particularly the research area of primary and integrated healthcare for innovation. So this is really the focus of our conversation for today. Like I said, it's a first conversation, but not in any sense the last conversation. We have much work to do and so on. What Corey and I want to do in the next 20-25 minutes is to set the stage a little bit. But setting the stage will continue after the next 25 minutes as well, when other speakers come and speak to you for the rest of the morning. We like to tell you a bit about the Primary Integrated Healthcare Research Network, how Saskatchewan sort of fits into that scheme, and the work that we hope to do, along with you all. So, really, the anticipated outcomes for me is at the end of this day, if we walk away being jazzed about some research possibilities and knowing who we'll talk to after today to realize those possibilities, around research with a real eye to implementation in the front lines. And that is the real key thing here, is to not do research for the sake of doing research. I say that as an academic, not just only to get a publication out, but actually to have research inform change. So that is our hope. So let's get on with it. And Corey and I am going to do either dog and pony show or duet. I like the duet piece better. So here we are. These are the objectives for the day. And I want to really start with two research projects that I think kind of really motivates us to realize what we can do, within the primary healthcare research network work. So here's an article. You can't see it, but that's okay. The title is what is important. Here's a qualitative study of a project that happened in Vancouver, BC, among HIV-positive patients. The intervention was to give them, people who do not have a cell phone, to give them a cell phone, a cellular program, and every week for 6 months, send text messages, SMS messages, just connecting with them. How are you doing today? And if there was no reply after a couple of days, follow up again and say, we haven't heard from you. How are you doing today? Is there anything that we can do? Really to kind of establish that support, to establish somebody care. And the qualitative research showed that this kind of intervention, even for 6 months, among highly vulnerable group of people in Vancouver, HIV-positive patients, had an effect on their psychosocial health. But it did not have an effect on removing barriers to care, like distance to a clinic or treatment center, and other social determinants, that they are faced with. But they did actually report that they felt like there was somebody else out there in a system who cared about them, and that motivated them to keep their appointments, go on time, take their medications on time, and so on. Now, just to couple that with a quantitative study, these are examples of primary healthcare research that I think has an impact, at the front lines. This is a quantitative study that a randomized control trial that looked at a group of cardiovascular risk patients with cardiovascular risk, and grouped them into 4 different groups: usual care, a nurse practitioner kind of directed care through phone calls, and a comprehensive clinic care. Those were the 3 approaches to care, and then they evaluated the outcome, across these 3 groups. They did find that the comprehensive clinic group had the best outcomes in maintaining or reducing clinical risk for cardiovascular disease. But importantly, all 3 approaches had the same cost propositions. In fact, the comprehensive clinic, although they had better outcomes, they did not cost more than the usual care or the nurse-driven care, which is interesting. So just want to show you these 2 research projects to get you thinking and get you motivated for the rest of the day, what we can do here in Saskatchewan. I'm not saying that we have to do exactly these things, but just to actually inspire you, motivate you to talk about what we can do in Saskatchewan around primary integrated healthcare. So what is SPOR, Strategy for Patient-Oriented Research? It is a national initiative led by Canadian Institutes of Health Research. About 2 to 3 years on now, we are still at the early stages. It has taken 2 or 3 years to get to a place where we are seeing some structures in place, research networks been funded, and research just beginning to happen. Interestingly, just last week, we got an email from the president, Alain Berset, saying that they are already thinking about evaluating midstream, 3 years into the, in fact, I kind of had a chuckle when I got the email. There's nothing much to evaluate because we are still very much in midstream. But the point is that actually CHR as a funder is quite on to looking at, the cost effectiveness. Are we really making a difference when, by doing research in a different way? About 15 years of research that I have been involved in, this is the first time that I have been involved in an initiative that is different, that is actually different in a way that is quite fundamental. We have distributed leadership, we have patients who are engaged, needs to be engaged in our research, and we have competition among and between provinces removed in order to actually have a capacity developed in all 10 provinces. The competition is introduced when the research stage is at the research stage, but at the beginning, when you're talking about developing the network, there's no competition. So this is a new way of doing research, and I'll call Corey to take us through the next few slides.
I'm it, okay. So patient-oriented research, this whole initiative from CIHR is quite different, and at least, when I started doing research, the idea of involving patients in research was perhaps if you had a focus group at some point with some of the people that you were working with and got their opinions, that was patient orientation. That's not really what we're talking about here. You can see that there is a lot more involved. Involving patients in a spectrum of engagement where we can actually involve patients as partners at every stage of the research is what we're talking about here. And there's a lot of links, I think, in this approach to the way we're trying to go about doing quality improvement in the province and with the lean approach in terms of a patient-first perspective of how we deliver care. So that really makes it exciting to have this tripartite leadership for our network involving both a research perspective, which Nazim is leading from the leadership group, a clinician perspective, which I'm representing, and then Margaret Baker representing from a government perspective, what some of the health system priorities are. You can see that what we want to do then is aim the research at things that matter to patients, things that, such as improving their health, improving access to the system, getting the right treatment at the right time, right location, being active and involved partners in the health care that they receive or their family members receive, improved quality of life and better outcomes from a patient perspective, and improving our ability to deliver services in a cost-effective manner tied with those better outcomes. So you can see there's a lot of resonance here with the way we're doing system planning as well, and this allows us an opportunity to tie that to best evidence and actually show that it's working. So these networks that the patient-oriented set of research activities that CIHR is promoting are just getting started. So we had a network announced a couple of years ago with youth mental health. This initiative on primary and integrated care is the second network that was announced, and then more recently now they're just working on phase 1 with the chronic disease management network as well, and there will likely be a few more announced as we go. This one is a bit unique though with the primary and integrated care in a couple of ways. First of all, in that there is a network established in every province. Every jurisdiction is represented. In the initial competitions that we had, there was a requirement that networks link with other networks across the country. The other unique issue here is a number of the institutes were involved in putting this one forward, and it's not just looking at what we would say is traditional primary care research. You'll notice the and integrated care, and the integrative aspect is meant to convey both integration across the health system, but also intersectoral integration, because the idea is many of the things that are important to our patients that are more the upstream factors that have to deal with prevention actually reside outside the health system too. So there was a real strong presentation at the network's inception from the Institute of Population and Public Health on the need to think about those aspects in the research projects that come forward. How is it that we can be linking across the system and across sectors? So the network itself you can think of as a network of networks. So we have this pan-Canadian SPOR network in primary and integrated healthcare innovations that acts as a bit of a support or a bridge between networks that are regionally based, mostly provincial, but in some cases, like the Atlantic provinces, several are partnering together. So we want to build on provincial, territorial, federal networks and national assets in community-based primary and integrated healthcare delivery and research. So it's supposed to help to foster new alliances between research policy and practice and see projects from research through to implementation at the front line. So the idea is to come alongside innovations that are being planned either from a regional or provincial health system perspective, and as they deal with intersectoral partners. A lot of emphasis on the intervention research coming alongside those natural experiments and opportunities, and things that are important to, obviously, from a patient's perspective and improving the quality of the system, putting those forward as research proposals, and then seeing if we can get interest from other provinces, other jurisdictions, to do more comparison in terms of how these types of innovations might be delivered in different types of systems or different parts of the country and different patient populations. And of course focused, as I said, on upstream prevention of the health problem identified to improve those clinical population health equity, and health system outcomes. And that's part of the reason that I've agreed to be the clinical lead here, to hopefully try to bridge some of that work between some of the prevention, intersectoral public health kind of work and more traditional primary care research as well. So I'm going to hand it back to Nazim.
Just want to pick up on the point about public health and the upstream determinants. I have been given to saying that, this is a research network, research approach that builds bridges between previously sort of unconnected research approaches, clinical, health service research, including large database sort of driven health service research, and population and public health. And through this research, we are trying to bring all those three ways of doing research together: clinical, health service research, and population and public health. So, so what does SPOR in Saskatchewan look like? And I think a number of you would have already heard about Saskatchewan Center for Patient-Oriented Research. This is the Saskatchewan's support unit. The support unit is infrastructure, a research infrastructure that exists in all of the 10 provinces, in each of the 10 provinces, in fact, that will support research in significant ways that is based on research networks, like primary integrated healthcare, like the mental health in youth, and chronic disease management, and others to come. So the focusing now primarily on the primary integrated healthcare network, what is the sort of the goal of this research? We want to build bridges between research through to the frontline implementation. So beginning from research idea or question development, its implementation, analysis, and then implications to the front lines. And how we do this is by involving not only researchers, who will be involved, of course, in that whole cycle, but also people for whom this research would matter, patients, decision makers, and policy makers, and so on. We'll need to really look upstream. It's an opportunity, folks, for us to look upstream and try to build research questions that take into account upstream factors, prevention factors, health determinants, social determinants of health factors, poverty, social housing, social support, etc. And the idea is then, if you were to take care of factors that has an impact on incidence, not just prevalence of factors, then we might be able to actually sort of have downward pressure to relieve the pressure on the healthcare system and the cost of the healthcare system and so on. And as I said, to link social determinants of health with health-related systems. We come some ways in this way of doing research in Saskatchewan. This slide sort of shows very quickly where we are at, where we have been, and where we are at as we speak right now. This is a phased approach to research in all 10 provinces. In phase 1, it was basically to create a network. We have to apply for some seed money, some developmental money to create a network in Saskatchewan. And then in phase 2, we had to reapply again to get funding for a 5-year commitment to have to be part of the pan-Canadian PICHI network. So we are to become formally a member network, a provincial member network of the pan-Canadian PICHI network, and that we achieved in March or April of this year. So we have 5-year funding for $1 million to manage this network and bring people together and so forth. And And part of this second phase is also, again, a sort of an innovative kind of a feature here, quick strike projects. These are projects of short duration, 6 to 12 months of time, with relatively small amount of money, but it's really a demonstration or proof of concept that research could be done by bringing people together, including those, those who advocate for patients and so on. And we were successful in landing one quick strike project that you'll hear about after our presentation. And phase 3 is the phase that is entirely dedicated for research. Longer term research, 2 to 5 years in time. Typically large projects that has multiple jurisdictions involved on a single topic or a single set of topics, working together to look at innovations that perhaps, cross-provincially, if there are 2 or 3 models of delivering care for seniors in community, how do we then actually understand which models are working, how they are working, etc. So it is that kind of research projects that will happen in phase 3. And we hope, we are expecting the call for these applications will be forthcoming in early 2016. Corey, is this yours? 5-year? Okay. So the 5-year network objectives for this are mentioned here, and I'm not going to take too much time. The first, right off the bat, we realize these days patients that we see in the front lines have complex needs, particularly complex social needs, not medical needs as well, but they come out of complex social needs. And we have to focus on those kinds of patients with complex needs first and foremost. And upstream prevention strategies, again, this is a recurring theme that we are talking to you about. Pathways to care, the transition between one level of care, perhaps emergency department, to community-based care, back to institutional perhaps if that is necessary. The kind of the transition that happens from one level of care to the next level of care, how do we actually manage that, in a effective way? E-health solutions. So how do we actually provide distributed care to regions where the capacity for care is not, not up to standards? How do we actually provide care that is cheap but effective to remote regions? Collaboration among and between patients and researchers, clinicians, practitioners, decision makers, and so on. New techniques and new ways of doing things, innovations that actually has to be evaluated to see whether they are meeting their objectives.
So our Saskatchewan network has been designed to include quite a broad range of stakeholders, and we're aiming to improve frontline patient care by researching these new practices and methods in primary and integrated healthcare, partnering with patient advocates at all stages of the process, as we've said. The initial focus has been a lot on individuals with complex health needs, and that's quite widely defined. This could be subgroups of the population with high needs, accounting for a significant amount of healthcare utilization time or dollars or both, or with complex needs that span healthcare and complex social needs or needs for supports in other jurisdictions. The aim has been to address the needs of the population by examining improved transitions between different levels and types of care, and where preventive upstream services can be integrated into primary health care. We will be hearing in just a few minutes about the Hotspotting initiative, or I think as we're calling it in the province, Connected to Care, but the CIHR group is still calling this Hotspotting, but this is really focused on that initial area that I'm talking about. So it's our one example of some quick strike funding dealing with these high needs patients, or patients that are super users or expensive users, frequent users of the healthcare system. Why are they using this most expensive healthcare mode? And how else could they be assisted? What other plans of care could be used to lower the cost burden for better efficiency, better care, those types of things. So you'll hear more about this from Jackie Quayle in just a few minutes. Future initiatives, though, I guess there's two sorts of processes involved. Each of the networks are going to be looking at what are the priorities in their jurisdictions, and that's one of the main reasons for gathering together today, is so that we have an opportunity to hear about what are some of the health system priorities from a provincial and a health region perspective, what are the patient perspectives and needs, what are the clinician perspectives and priorities, and see if we can find that sweet spot where there's interest between those groups from our region's perspective, from our network's perspective. And that will be a good opportunity for us to start looking at where should we be putting our efforts in anticipation of a call for future funding. At the same time, though, other networks are doing the same sort of thing at different stages across the country. And so we're already starting to receive word from some of the other jurisdictions around these are the types of priorities or issues we're starting to discuss, and they're looking now for partners. And so there's going to have to be this dialogue back and forth between what are things that may be driven because it's a high need, we have high capacity and the right groups of clinicians, researchers, patients, etc. here, or things we might be more interested in partnering but perhaps not leading with other jurisdictions as we look to advance forward future funding opportunities. These are just some examples from the Alberta network on some of the projects that they're currently working on or developing, just as an example. And I think as you look through this list, you can see some that are fairly traditional when it comes to improvements in areas of primary healthcare delivery or outcomes for patients in an ambulatory setting. Some of them you can't see at first blush where some of the integrated care aspects are, but buried within them, those are some of the things that they would have to be showing if they want these to be successful funding. And they might be looking for partnership with Saskatchewan as an example in some of these research opportunities. But you can see here, just as an example, with diabetes foot ulcer care pathway, scale up and spread, have you considered, for example, a health equity component within a diabetes pathway? There are different needs for individuals with different types of capacity, whether there be homeless individuals perhaps, or low income, and the ability to actually follow a care plan or a pathway might be very different. And there might be some upstream issues around early identification of diabetes or lowering risk factors that would perhaps be a part of that scale up and spread question, just as an example. The membership in our network, I think this is my time to sell you, I guess, on membership. What's in it for you? What's in it for our patients? Certainly funding is what usually draws people to research initiatives. What are the funding opportunities? This is a little different and a little more challenging for us. Part of the need to get together early like this is because there's matching funding that's needed for these initiatives, and that takes time to arrange. It's good to leverage funding, but it's not like some of the other research projects where you're solely relying on the funding from the research institution. Collaboration. So this collaboration, I think, between people in the room here and others that we identify in the province, but also with other networks, and trying to build this collaborative approach into policy, research, government, nonprofits, health regions, etc. Essentially bridging those areas Nazim talked about, the policy, the health system's delivery, the patient perspective, as well as those research and best evidence needs. Bridging that research to frontline implementation. And of course, working toward improving individual and population health, health equity, and health system outcomes, which is part of our statement as a network. So I think there's a lot of opportunities. There's opportunities, I think, for getting new partnerships and identifying new groups to be working together, identifying this intersection between the research mandate and our own priority areas that you'll hear about a little later in the morning, and our local level needs, which I know there are some regional health authority and individual clinician representatives here as well. So we hope that this is an opportunity for all members, if you join, to collaborate across these jurisdictions to implement evidence-based solutions to these problems that we face. So I'm just going to hand it off to Nazim to close it out.
So folks, we are just about to end our presentation and invite Jacqueline Quell up to the podium. And I think, like Corey said, membership in SPOR PICHI is really, I mean, all you have to do is actually ask for membership to declare your intention to be a member, and we will actually include you. And every other network across the country are doing similar exercises as to what we are doing here. There are just some examples, illustrations, of type of people who can be part of this member network. And we want to show Janice's contact information, and also, last but not least, none of this would happen without the really meaningful partnerships by many people coming together. So we want to acknowledge SHERF, CIHR, Quality Council, Saskatchewan Health Region, as well as University of Saskatchewan. So it's my distinct pleasure right now to introduce Dr. Jacqueline Quell. Actually, Jacqueline and I go some ways back when she was, she has dreams in her eyes and want to become a researcher, and so she's a graduate of our program, Community Health Epidemiology, had gone to McGill and did a PhD. And as many of us would wish to see, it's wonderful to have people come back to this province and put their expertise to use. So Jacqueline is one of them. Jacqueline Quell is a senior researcher in the Health Quality Council in Saskatchewan. And Jacqueline is going to tell us about the hotspotting research, which is one of the quick strike projects that we're just getting funding.
Good morning, everyone. I'm going to talk to you less about the specific hotspotting project and tell you more the story of it. And I hope that it will influence you to find out what you need to do to make your own research successful within this funding opportunity. If you want more details on the actual project, I will be talking ad nauseum about it over there at the poster presentation if you're interested in it. I want to start by telling you the genesis of how we eventually got here, because I think that might be important for your own journey. Briefly describe the project and then the indications for the future. The Hotspotting project started back in 2013. It was a Saskatchewan initiative, and the idea was to identify the most expensive people in the province who are the smallest number of people but use the greatest proportion of healthcare resources. For example, only 5% of people in the healthcare system can use up to 50% of all the resources. And this has an excellent cost-benefit ratio. For that one person who's so expensive, if you can intervene, you can save up to $1 million in a single year. And that's why there is so much focus in the province and around Canada and the worldwide in this hotspotting. But the question is where to start with that. HQC uses administrative databases, and I can tell you more about that if you're interested, but it's a source of data for us to identify these people. We identified the most expensive healthcare users in fiscal year 2012-13 in Saskatoon and Regina-Capel health regions, which was a total of just over 8,000 people, and we analyzed the data to identify subgroups within the study population. And the results are obvious. If you really want to understand all of this, I will be giving a presentation at the School of Public Health on November 5th, and you actually will understand what all these results mean because I'll take you through it, but I'll give you the cheat sheet on the results. How you read this table is that on the very top, in the category of premature babies, within this category of the most expensive people in the province, there were 419 babies that had 740 hospitalizations. They accounted for just over 5% of the entire hotspotting cohort, and only 3% of all those hospitalizations within that cohort. And their average cost in that fiscal year was $66,286. These are the results of everything, but where to focus? Where do you want to get the biggest bang for your buck? And we identified 3 different groups. The first, the bottom red line, is the alternate level of care. These are people who are older, they can't live in their home anymore, but they don't really need an acute care bed in hospital, but they have nowhere else to go while they're waiting for a long-term care bed. I picked them because they are the most expensive. You can see their cost is over $87,000 per year, whereas everyone else is in the 60s. Most expensive. The second group is the medical harm. These are people who go into hospital for any reason at all and something bad happens because of the medical interventions, typically infection or there's some sort of mechanical failure. And I identified this second group because these are the most preventable. They should never be happening if we're able to do our job correctly. The third group we identified were people with mental health and addiction problems. The reason they were selected is because these are the people who interventions can have the most impact on. For example, if you have a spinal cord injury, there's really nothing we can do except to give you a lot of expensive care because that's what you need. You have a spinal cord injury. There's no other solution for that. But with mental health and addictions, there are outpatient programs. There can be hospitalizations. There could be using some of the texting to get people to follow their HIV treatments. There's so many different interventions, and that's the most amenable to treatment. So those were the 3 we focused on. But then an opportunity came up because our CEO, Gary Tier, right over there, is friends with Walter Woodchis at the University of Toronto, or University of Ontario in Toronto. No, University of Toronto. Thank you. Walter does exactly the same sort of research, and he was doing it on his own. And Gary said, why don't we meet and see where our research connects? And we did meet over the internet, and it turns out that they did exactly different methods to come to exactly the same conclusions as we did in the areas to focus on. And this merging, this melding, was the start of our partnership. And I do think that is part of why the grant succeeded. We had already started doing this on our own, and then the opportunity came up to say, hey, we can put in a quick strike grant. And that's exactly what happened. The grant was successfully funded. I definitely feel that we are in the awkward stage now because we're trying to figure out how we all work together. Ontario has its own team of investigators. The primary investigators are Walter and Claire, but they have numerous people, about 5 or 6 others that have patient advocates, mental health and addiction specialists, psychologists, psychiatrists. They have their whole team, and I've connected with them, but most of my interactions come through the Ontario team. In Saskatchewan, we have our own team, Corey, Nazim, and Margaret, Gary at the Health Quality Council, and we've added 3 others since it's been successfully funded. Valerie Bradfield from First Nations and Métis Health Services, Maureen Anderson from the Public Health Observatory, and Merritt Osmond from the Health Quality Council, who will be helping with the economic analysis of it. And I'll take a little bit of time to harken back to what Nazim said about, in all his years of research, he's never done research like this. And I really have to agree with that. Some of my background is I used to be a physiotherapist, so I've done the frontline work, and I got tired of seeing the same people come in for the same preventable problems time and time again, so I wanted to go more upstream, get into research, have the stars in my eyes. And then the academic world wasn't what I thought it would be. It was profoundly not grounded in the real world with some of my experiences, if you know what I mean. One of my classmates was doing this fabulous, amazing project. He just talked for ages and ages about it. And when I asked him, and how will this be translated to the real world? He's like, oh, it won't. Not at all. He wasn't bothered by that. But okay, I'm just waiting for it to go off again. And so I'm a senior researcher at the Health Quality Council, but I've specifically shied away from academia because I wanted to be real world, practical, let's help the patients. That's what it's all about. And it's been so wonderful to work with this team because having the clinical lead, the research lead, and the policy lead, they're able to balance each other and help me push the research through in ways that weren't possible before. Specifically, I was identifying risks. I don't think I'm going to be able to get this data set in time for this Quick Strike project. And then Corey knows many of the clinicians and the emergency department database people. He's like, we need to educate them. We can remove some of those barriers. Well, now I'm having a problem with ethics. And Nazim's like, well, I'm with the university. I can help with that. And then when it comes to getting data from eHealth, Margaret is able to say, well, I'm in government, I can just walk down the hallway, I can see what I can do to help. So they identify barriers and they remove barriers. And the best part is they can keep each other in check as well. And Nazim, you have never, ever been one of those people to not be realistic and focused on it, focused on the project, but often like scope creep can happen, or it'd be great, we could get a paper out of this from the research perspective. Policy's not gonna care about that. And given these short, quick strikes, we need to have that stay on target focus. And that is what is so exciting about working on this project. And that's why I'm excited that we have this opportunity here for that. Back to the project, the specific objectives of the hotspotting were first to identify and describe subgroups of people with mental health and addiction disorders. And once we identified them, we want to describe the trajectories of their health services utilization. Do they stay as a low-cost user or begin and stay? Do they begin low, become high? Do they stay high at the whole time? We don't actually really know that. Some of the research has indicated maybe they don't stay high for that long. We need to understand them before we can start to affect them. We'll then create a statistical model and try and predict these trajectories. And the idea is that if you can predict, you can prevent. The third objective, and this is what I like, we've done the research, we've used the databases, we're going to get some excellent papers out of it, but so what? Let's do something that affects the real world. And so the third objective is to develop an inventory of all mental health and addiction programs and create an alliance of people who create and deliver and also use these programs. Because especially as the ex-physiotherapist in my past life and having been a patient in the healthcare system myself, the people with the best insights are the ones using the program. And the healthcare system wasn't made for the benefit of us clinicians and people who work in it, it was for the benefit of the patients. And the SPOR absolutely demands that it be there, and we're stronger for it. The idea is to help the treatment of mental health and addiction problems move from being reactive to proactive, and to identify factors that are associated with becoming a super user, because once you know what these are, as Corey and Nazim have said, you can move further up. And if you know that, for example, eating green jelly beans means you're more likely to become, addicted to something, let's intervene when the kids are just eating green jelly beans, things like that. Why was the grant successful? One is, and this is the biggest reason, I think, we were a perfect fit for the SPOR priorities. They wanted complex care people, and that's exactly what hotspotters are. It's not so much that they're necessarily really sick, but they're getting fragmented care, and it's not just in the healthcare system. They, for example, may be homeless, they have some social issues, they're in part of the justice system, and we have to have a much bigger view than just the healthcare system. And again, we're focusing on going upstream, which is exactly what the people wanted. I'm just going to digress for a little moment again to talk about a project that wasn't funded by CIHR, but I'm really disappointed that it wasn't, and that's the Dementia Radar Project, because, and that's Deborah and Julie right there, and they're on the dementia team with me. Well, actually, I'm on their team. And they have all the pieces in the right place. For 8 years, they've been working with people in the regions, having patients come. They have all of those pieces in place already, even before the SPOR and the PICHI. But I guess that dementia just was not as attractive or as complicated yet for the mental health and addictions, but especially for people who are interested to focus on seniors or also emergency department flows. The research we're working on is to try and keep people with dementia in their home longer so they don't become that alternate level of care. See, we're coming back to that. Those three groups that I identified, when they're not in hospital taking up those beds, then you can improve the patient flow, the ED, the waits. So whoever is from the government and you're going to be doing seniors and ED flows, talk to them. They have a lot of good things going on there. I do feel other things that helped us with the grant were having an established partnership. I think it was obvious to the group in CIHR that we were already working together, we already had a plan for everything, and that we would be able to succeed in a short time. And that would be my advice to you, is don't say, oh, there's a grant, let's make something up. Keep working on it now, and then it will be such a nice fit for where you're going. The future, ideally, is Joanne Franco here at all? Because I put this baby in for her. That's her one. This is eventually where we'll be going, because like any good research, you actually get more questions. Some of the subgroups we'll be looking at would be to break off people with schizophrenia from those with substance abuse issues, looking at First Nation and Métis people, immigrants, rural versus urban, mental health care needs, very different. There's so many new projects that can come out of this. And then the two other groups that I previously identified, I think there's so much to be done in there as well, the alternate level of care and the medical harm. This is just a little taste for you. If you really want to understand more about the project itself, again, I'll be over there with a poster at some point, or you can come find me at table 2 in the afternoon. Thank you.
Thank you, Jacqueline. That's an excellent way of illustrating what it is that we're trying to do with this network. I think Jacqueline touched on all of the points that are meant to be incorporated from inclusion of patients, complex needs, something that's really addressing a frontline priority for healthcare, something that's addressing the needs that we have as a healthcare system, but includes other jurisdictions, it includes multiple disciplines. We have a few minutes for questions. Now these can be either for Nazim or Corey or for Jacqueline. Do we have any questions that have come from the presentations? Yes, Dr. Shah.
Hi, Saqib Shahab from the Ministry of Health. So part of my question was answered by showing the research priorities in Alberta, for example. But I was wondering that what is similar and what is unique in Saskatchewan versus other provinces. So maybe it's more upstream linkages and maybe more alignment with some government priorities like mental health and addictions and seniors. So there's one question. And the other was that when you talk about networks across Canada, that's great, but what are your networks within Saskatchewan, for example, in terms of northern, rural, those kind of things?
Okay, I'll let one of you come up and address it. Nazim or Corey?
I'll give it a try, Saqib, if I heard you correctly. I think we are still at a fairly early stage. Although we have a quick strike project, that is up and running right now. The purpose of this kind of a gathering is to try to exactly address kind of the concern or the issue that you put on the table. So glad that it got put on the table right away, because I think we need to talk about how Saskatchewan as a province at this point in time, with the demographic we have, with all the circumstances that we are facing right now in the healthcare system, in social systems, how do we respond to a pan-Canadian opportunity that is trying to align research better with frontline care, that benefits patients? How do we do that? Not just patients in Saskatoon or Regina, but in all across, in Weyburn, in small towns as well as actually culturally, heterogeneous, First Nations, Métis communities, and newcomers to Saskatchewan. That's precisely the issue, that we have to grapple with. I don't think we are the only people in this, in the province, in Canada, that has to grapple with that. I think every province has to grapple with that, but we have our own response, which will not be exactly like Alberta's response, We want to show you those questions today. We just received them on Friday, as a matter of fact, through their coordinator, their network coordinator. We want to show you these are the types of conversations happening right now in Alberta. Those are not the best questions, the best research projects, but they're just a sampling of what is actually happening in the province next door, But we'll have to do our own conversation and come up with our own list at the end of today or in the next several months that we can then share with other networks, provinces, and ask whether there are partners in other provinces who can partner with us.
I think just to add briefly onto that, I think every province is a bit different. Some provinces like Alberta had a pre-existing, quite strong and large developed primary care research network, but it wasn't focused in the specific area that CIHR wanted to. So they're having to develop that integrated part and look at how that existing network will morph into this kind of network. Other areas like Saskatchewan, we've had a strong tradition already on the quality improvement work, and we have some well-developed questions that need answering, and a lot of individual clinicians who may have been going about some of this research, but we hadn't developed them yet into this type of a network. So where the network development is key for us at this point in making, looking for those existing collaborations between provinces and trying to use those as a catalyst to move forward. So every province is at a different stage, and I think the strength for us is trying to connect, find out who those interested clinicians are, link it to the policy questions that are important right now, and be ready for the call that comes forward.
Good, thank you. I might mention Dr. Shahab is the Chief Medical Health Officer for the province of Saskatchewan, in case you don't know it, so we're very pleased that you were able to make the trip up and join us today. Other question? Dr. Caroline Tate.
Yeah, hi. I have a question, actually a couple. I have a comment and then I have a question. And my comment is around Dr. Quayle's remark about academic and it being very far from community, and that I would say that we have actually moved beyond that. And many of us have had long careers now, working very closely with communities, and I would hope being extremely relevant. And as a Métis person, I struggle all the time with convincing our communities that this is the case, because there is this straw man of academia that sometimes is pushed around, that, you know, that we are somehow up in the ivory tower being incredibly irrelevant. And I would say that I would challenge that a bit, I guess, to say whether that's true or not. And we actually, bioethics is a good example of where we need people looking at a topic like bioethics from a very philosophical point of view, where the relevancy in terms of the end of death stuff, for instance, end of life, I should say, end of life, is a really important area where we do need academics thinking about the ethical questions that impact, and they may not be out on the street and they may not be in the community, but we do need that. So I would caution a little bit around that straw man as we move forward. The second thing that I would ask is within the SPORs, what's incredibly interesting for me in terms of the Indigenous piece is the challenge between balancing patient-oriented research with community-oriented research, and how do we move forward with the voices of patients, but at the same time respecting the principles of CIHR, but also the Indigenous principles of OCAP, so ownership, control, access, and possession. The Hotspotting is a very interesting project for me in that regard, because I think, okay, so you're looking at patient groups, but we know inevitably that the Indigenous population is going to figure as a variable within the Hotspotting project. So I'd like to know more about the partnerships with the Indigenous community in the province, or the Indigenous stakeholders, I guess, and how that is being balanced within a project like that, and what then is, what happens to the data, and how is the data governed given the Indigenous principles of OCAP and the CIHR guidelines.
Jacqueline, do you want to?
Thank you very much. I didn't catch your name. Caroline, hello, and thank you. Yes, and I was exaggerating a bit with the ivory tower of research, and I'm so happy that your experience has been different, because I've had pockets of common sense in there. Maybe it was just the McGill experience as well, so a little bit biased there, but thank you so much for sharing that. And it's true, because I do see it moving more towards that research is not the ivory tower anymore. And this is still, though, Nazim had said he's never been involved in a research project like this before, and I haven't either. I feel incredibly well supported with this team to be able to have it make sense. And because we only have, well, less than 1 year to make it all happen, we've really got to stay on target. And this is forcing us to do what some people have been trying to do all along. Like, actually, the dementia team has been doing that all along. So I'm happy you've had a different experience, and maybe I'll get slightly less negative over time. You had a lot of great comments about Métis and First Nations, Indigenous people, and when we were doing the Hotspotting grant, it came up very, very quickly that we would apply for it, and right away we put it into the grant that we absolutely need to have patient and family representatives. We don't have a lot of time to get them right now, so we're putting in the grants, and we will follow up with them. And that's what I continued to do after the grant went in, even if we weren't sure it would be funded. I contacted Gabe Lafond at First Nation and Métis Health Services, and I was pretty sure that Indigenous people would be an important subgroup within the mental health and addictions, and I was unprepared for how important they would be after talking with Valerie Bradfield and such. She was saying that in the mental health and addictions programs like methadone, that 70%, 70, people were of Indigenous descent, and therefore First Nation Métis hugely important to have in there. So I've started trying to pull those people in, but we've had one meeting already, and we're just in that trust building phase and getting people to belong to part of it. We're starting on it. As Nazim said, it's just in the beginning. We're not there yet, but we absolutely recognize the importance. And I think you might have had a different question that I can't remember. Or not.
Well, I think I don't want to really read into the important presentations that we need to hear from our colleagues in the government. But Caroline, you as always, put the right question on the table. How do we actually balance patient and community, needs and perspectives? Well, this is a work in progress. I wish I could tell you in definitive terms how we are going to do it. I can't, and because it's actually not just my. I'm one person, and there's a whole bunch of people in this room, who's, and others who are not in this room, whose perspectives on that issue alone, patient and community, need to be balanced, need to be taken into account. It need to be there. There are many people, in terms of actually being responsive and respectful and relevant for First Nations Métis populations, as well as actually all other, culturally minority, populations, is important. That is actually where this project will either fail or succeed. I believe that. We have to work with people like you and others, to make that happen, who bring a lot of experience and long commitments, to make that happen. So, that's how I would kind of really, respond to that very important question. Those kinds of difficult questions, I think, need to get on the table when we talk among ourselves after lunch or through question and, Q&A periods, because this is not about just sugarcoating anything. It is about actually wrestling with difficult issues, but still coming away with something useful, for the province and for this healthcare system and for everybody. So thanks for that very important question. I'm going to
I think, Beth, did you want to say something? I saw you had your hand up too. So Dr. Beth Horsburgh is also on our Leadership Council. She's an Associate Vice President of the University and one of the people who's been doing the heavy lifting to create SKIPPR, the Saskatchewan Centre for Patient-Oriented Research, which has an overarching role in this.
Thanks. And I was just going to make a comment. I was wondering if Gary Tier was going to make the same comment. But in response to Caroline's question, it's a great comment and question. Thank you, Caroline. And that is, we're just getting up and running this fall our Saskatchewan support unit, which is a service center which will be available, and those services available in both Regina and Saskatoon and right across the province using our distributed academic health science network, video conferencing, and what have you. But one of the platforms, and there are 6 platforms of services, but one of the platforms will be outreach, Indigenous outreach and engagement. And the Indigenous Peoples Health Research Center, led by Joanna Piscanu, will be receiving approximately $500,000 a year in additional staff to provide that kind of expertise. We also have what we're calling skipper methodologists. These are researchers with expertise in things like Indigenous engagement and or modeling, economic cost-benefit analyses, those kinds of things, that will also be available to network teams and also other patient-oriented research groups in the province. So we're still getting that up and running. We actually have our meeting with CIHR this week, the adjudication committee. We're traveling to Ottawa. And so we will be back to all of you. We'll be sending tweets out and more formal communications that you know what's going on. But we are the only support unit that we're aware of in Canada that will actually have its own Indigenous outreach and engagement platform, because that is reflecting the core values that have been put forward by the working group. So just a little bit of an aside, but it was a great opportunity to bring that to everyone's attention.
Thank you, Beth. There's going to be some excellent resources that are going to be available to the teams once Skipper gets up and running. We're all looking forward to seeing that. All right. Oh, yes.
Hi. I'd just like to say thank you for the presentation, and I'd like to say a special thank you to Jacqueline for recognizing the importance of patients involved in this process. I just had a couple of questions, and it has to do with patients' engagement. And I want to know, what does patient engagement look like? How does this process engage patients? What are the values that this is built on? And who owns the info? And what does the relationship look like at the end of this?
Those are big pieces. Who wants to take on that question?
Janice, I could speak to that.
Sure, Gary.
So Beth got to jump up on the Aboriginal piece, and I can jump up on the patient engagement piece. It's an excellent question, and you know, this is, as Corey was saying, is doing research in a different way, whereas patient-oriented, and really the ultimate goal is that elements of this will really be patient-led. It's about engaging patients in the A to Z, essentially, of what we do in research. So there's already been some, quite a bit of work involved, you know, going right back to the Patient First review that happened in 2009 through the health system, and the trajectory that put the health system on in terms of engaging patients and families in having a greater input into what the healthcare system does in terms of how it organizes itself, how it improves itself, and that sort of thing. There's been some infrastructure and some development there to develop resources and capability within health regions. Still a long way to go on that, but a fair bit of work that's been initiated along that line. And what we're trying to do is really build on that work then for the research component. So what it involves is really being quite purposeful about seeing how can we engage patients at all levels, both at the level of more active engagement with the research in the design and the questions that are asked, in understanding why this is important and what's important, to helping to interpret and understand and translate the meaning of the results of the research, to getting engaged in priority setting of what research do we do anyway. And that very much parallels what we're trying to also do in the healthcare system around engaging patients in improving the services that are delivered, to the planning of services that would be delivered, to the strategic planning that happens in the health system around what are we going to improve, what do we want to develop going forward. So we're really trying to build on what the health system has established, and that's why we positioned in the SPOR unit, the support unit that we're in the process of developing, we positioned that patient engagement component, or that platform of services within HQC, because we're also helping to coordinate and lead the piece that's happening in the health system. So we're trying to leverage what's happening there to give us a leg up. And as Beth said, we're probably also, we've committed a lot of resource to engaging Aboriginal, First Nation, and Métis peoples in this work, probably more than any other province. Similarly with the patient engagement piece as well, we've probably got more FTE type investment in getting that happening than I think almost any other province's SPOR support unit.
Thanks. I think we're...
It's a really good question, actually. And you know, we're not there yet, to be really honest. And the rest of the country isn't either. I was at, Gary went as well, we were at the first SPOR forum, the annual forum that was held 6 months or so ago in Ottawa with the other support units. And some of those support units have already been up and running a year or two. So we're still catching up in terms of getting there, and so is the rest of the country. But I think we're getting a much better sense of what it needs to look like. And certainly we've had 4 patient and family advisors sitting on our writing committee that's developed the proposal for the support unit. We are really pleased, we call it the Saskatchewan Advantage, that we have a province now that's actually delineating a small number of priorities with patient engagement embedded in that process. So we feel we don't need to reinvent that process, we'll be able to build on it. But the ideal is to have patient and family members involved right from setting the research questions all the way through. The reality is this opportunity got up and running over a year ago before we had patient and family engagement in place. So we're playing a bit of catch up. It's not perfect, but that's where we're all trying to head and get better at it as we go.
I just want to, I forgot to get to one of the points I wanted to make, which was what's involved in getting patients engaged. So part of it is about training and education, helping people to understand what being involved in research is about, and really orienting people to the research process, both on the researcher side or the academic side, as well as on the patient side. But then there's also peer support, so enabling people who are getting involved to have a buddy, if you like, who's been there before, to help them understand how they interact with the research groups and that sort of thing. So there's a number of layers that, that get built to enable this to happen. It's not just sort of wishful thinking.
I'm getting a sense with the number of hands going up, there's a lot more interest in this, and I can tell you, trying to put everything into a 5-hour workshop today, we have a lot more sessions that are going to be coming up on this, and so I think we might have to carry these on in the break times, and I know Jacqueline, you're wanting to speak to it. Okay. Okay.
Maybe a little flaw here and there, and maybe you should think about it differently. And then I said to her, and that is exactly why you should be on the team, because she will come in with the ideas of what to do with helping people and patients adapt in. So that's my answer. That's very short. I'm done. I just thought it was